In any complex situation, there's that impulse, isn't there, to latch on to the single clearest piece of information you can find, that one test result, that one compelling statistic, maybe that one strong signal, and declare, aha, that's the answer.
Mm-hmm. It's tempting.
But what if that impulse, that urge we have to simplify, is precisely the enemy of accurate understanding? What if relying on just that one data point is what leads to, well, imprecise and incomplete information, resulting in solutions or treatments that are fundamentally, as the sources put it, unreliable?
It's a stark warning, certainly.
Yeah, it is, and it's drawn from the sources we're exploring today, and it really cuts right to the heart of accurate diagnosis and effective problem solving. Not just in medicine, I think, but really in any field that tackles complexity. Welcome to the Deep Dive, the show where we aim to extract the essential insights from the information you share, helping you cut through the noise and become truly well-informed. Today, our dive takes us into the fascinating challenge of complexity, but we're looking at it through the lens of medical diagnosis, specifically focusing on musculoskeletal conditions and orthopedics.
A really good area to explore these ideas.
We've been poring over texts that bridge that crucial gap between theoretical knowledge, all those facts and figures you learn, and the practical application needed to arrive at a robust, reliable diagnosis out there in the real world. To guide us through this material, to help us synthesize all this diverse information and connect the dots into a clear picture, I'm delighted to be joined by our expert guide today. He's uniquely skilled at pulling apart intricate subjects and revealing the core principles at play, drawing from extensive experience and a deep understanding of diagnostic processes. Welcome.
Thank you. It's a real pleasure to be here, ready to explore this fundamental approach to tackling complex problems, which, as you say, is relevant far beyond the clinical setting.
And it is indeed a big problem getting the diagnosis right. So let's jump straight into our rapid-fire setup to frame this discussion. Based on the material we've reviewed, what would you identify as the fundamental, maybe even the existential challenge when diagnosing issues within a complex system like the musculoskeletal one?
Fundamentally, I think the challenge lies in the inherent complexity itself and also the significant overlap of symptoms between different conditions. It's quite pronounced.
Okay.
The human body, particularly the musculoskeletal system,
Yeah.
Muscles, bones, joints, nerves, it's an incredibly intricate network.
Yeah.
Pain or dysfunction in one area can easily be caused by a problem originating right there locally, or it could be referred from somewhere quite distant, or even driven by a systemic issue affecting the whole body.
Right.
The sources really underscore that symptoms alone, or even the signs you find on examination, are often quite nonspecific.
Right.
Making a precise diagnosis based on just one piece of information becomes incredibly difficult. It's a bit like trying to diagnose a complex network failure based only on a single error message. It gives you a symptom, sure, but not necessarily the root cause or even its location.
Okay, so overlap and complexity are the starting points. Given that, why isn't simply relying on a single high-tech test or scan, like an MRI, which I think many people might assume gives you all the answers, why isn't that sufficient to cut through the complexity and give you the definitive diagnosis?
Well, single tests, including advanced imaging like MRI, they are tools, powerful tools, absolutely, but they're just one component of the overall picture.
Just one piece.
Exactly. And the sources make a really crucial point here. These tests often have variable sensitivity and specificity.
Can you just quickly remind us what sensitivity and specificity mean in this context?
Of course, sensitivity basically means how well a test picks up a problem when it is actually present. High sensitivity means fewer false negatives. It's good at finding the condition. Specificity, on the other hand, is about how well the test confirms that a positive result truly indicates that specific problem and isn't being triggered by something else. High specificity means fewer false positives.
Right. Got it.
So if the sensitivity or specificity of a test is poor, or even just variable, it can easily miss a problem that's genuinely there that's a false negative. Or perhaps worse sometimes, it might show an anomaly, something unusual on the scan that isn't actually the cause of the patient's issue at all. That's a false positive.
And that leads to overdiagnosis.
It can, absolutely. It leads to overdiagnosis and potentially unnecessary interventions or treatments. A scan might show a finding, maybe some age-related wear and tear. But without the clinical context, without the patient's story from the history and the findings from the physical examination, you can easily misinterpret its significance. You might end up chasing a red herring, the incidental finding on the scan, while completely missing the real pathology that's causing the symptoms.
Like focusing on one department's report without knowing the whole company's process flow.
Precisely that kind of analogy. You need the bigger picture.
That makes perfect sense. It's just one piece of the puzzle, and potentially quite misleading if you look at it in isolation. This leads us neatly to the core concept championed in these sources, the diagnostic cluster. What exactly constitutes a diagnostic cluster in this context, and why is it presented as so indispensable for getting an accurate diagnosis?
A diagnostic cluster, as articulated in these texts, is really the deliberate, systematic integration of information from all the fundamental pillars of diagnosis.
Which are?
These are the clinical history, essentially, the patient's story, the physical examination, what you actually find when you assess them, and then the diagnostic testing or investigations, the objective data you get from scans or other tests.
History, exam, tests.
Exactly. And the sources argue quite vehemently that these pillars must be used in conjunction, not in isolation. They have to work together. This integrated approach is essential because, as they put it, it's the cluster approach one needs to use in everyday practice to achieve reliable diagnostic accuracy. Unlike focusing on isolated findings, which, as we've said, can be unreliable, combining multiple related pieces of information creates a much stronger, more coherent picture and significantly increases the probability of identifying the true underlying issue.
Like cross-referencing multiple intelligence sources before making a big decision.
Precisely. It builds a much more robust case.
Okay, let's really unpack this then. We're talking about combining history, examination, and testing, these three fundamental pillars of diagnosis, as the sources describe them. And the emphasis, as you say, is absolutely on using them together, not as separate silos.
Absolutely. The texts lay these three elements out as the foundational basic ingredients, if you like. However, their true diagnostic power is only really unlocked when they're synthesized. The critique offered in these sources, and I think it's a fair one, is that many traditional textbooks focus excessively on detailing each element in isolation. Here's how to take a history chapter, here's how to perform this specific test, here's how to read that scan.
Right, they break it down into pieces.
They do, but they often fail to adequately illustrate the crucial next step. How do you integrate all these findings into a coherent diagnostic strategy in practice? And this is where the cluster concept becomes so essential for practical, everyday diagnosis. It's about putting the pieces together.
So let's begin with the first pillar then, the clinical history. Beyond just asking, where does it hurt? Okay, why is history taking described as so profoundly crucial in formulating a diagnosis?
Oh, history is the absolute bedrock. It really is. It's where you begin to build the case, where you start to elicit the characteristic patterns that help differentiate one condition from another. A patient's description provides invaluable clues about, say, the mechanism of injury. If it was sudden and traumatic, how exactly did it happen? What position were they in? What did they feel at the time? Snap, pop, tear.
Those details matter.
Hugely. It also reveals the onset and progression of symptoms over time if the issue is more gradual or degenerative. Did it come on slowly? Has it been getting worse? What makes it better or worse? As one source highlights, even in cases of apparent trauma, the patient's account can point towards specific areas of injury or perhaps underlying vulnerabilities you might not suspect just from a superficial look. But critically, history goes far beyond just the immediate complaint. The sources strongly emphasize understanding the individual patient's context, their lifestyle, their background, their expectations even.
Lifestyle factors. What sort of specifics are they highlighting here as being diagnostically relevant?
Well, they delve into details like occupation and leisure activities. And these are just, biographical footnotes. They inform the types of stresses and strains the body is regularly subjected to.
Okay.
For instance, someone with a history of heavy manual labor, particularly involving repetitive overhead work, or using vibrating tools, think construction workers, mechanics, they have a significantly higher likelihood of certain issues like rotator cuff tears in the shoulder.
Makes sense.
They cite specific examples too. Weightlifters are known to have increased rates of acromioclavicular joint arthritis, that's the ACJ, the joint right on the top of the shoulder, simply due to the specific forces placed on it during heavy lifting. Contact sport athletes, say rugby or American football players, are predisposed to things like posterior labral tears, damage to the cartilage rim at the back of the shoulder socket, often from tackles or falls onto the arm.
So the activity directs your suspicion.
It absolutely does. These details from the patient's everyday life provide crucial context and act as powerful weighting factors when you're considering the potential diagnoses. It's like understanding the operating environment and usage history of a piece of equipment before you diagnose its malfunction.
That's fascinating. The patient's story isn't just about symptoms, it's about their entire interaction with their world. What about their broader medical background? Are other health conditions, comorbidities, or previous issues significant?
Absolutely crucial. And the sources provide some compelling examples of specific associations here. Comorbidities, other health conditions the patient has, are highly relevant. For example, conditions like diabetes, thyroid disorders, and even Parkinson's disease are linked to a higher incidence of adhesive capsulitis, which most people know as frozen shoulder.
Right, I've heard of that link.
Obesity is also strongly associated with needing surgery for rotator cuff tears, particularly with a higher body mass index, suggesting increased mechanical stress or perhaps metabolic factors playing a role. And interestingly, they note that glenohumeral joint arthritis, that's the main ball and socket joint of the shoulder, is more likely not just in older patients, say over 70, or those with a history of dislocation, but also surprisingly if they happen to have osteoarthritis in their knee.
Really? Knee arthritis linked to shoulder arthritis?
It seems so, yes. It highlights how interconnected the body can be in ways we might not immediately expect. Of course, a history of previous fractures, surgery, or even seemingly unrelated issues in the surrounding areas is also essential context. You are, in effect, assessing the entire system's history, not just the history of the component that's currently causing trouble.
Right, building that really rich tapestry of information just from the conversation. That naturally moves us onto the second pillar then, the physical examination. The sources describe this element as both a science and an art that requires significant practice and refinement. How should one approach the physical exam systematically to get the most out of it?
Well, the traditional systematic approach is usually presented as a sequence: look, feel, move, and then special tests. But the sources stress this isn't just a rigid checklist to be rattled through mindlessly. It requires keen observation and clinical reasoning throughout the entire process.
So, starting with look, what are you looking for?
When you look, you're conducting a careful visual inspection. You're looking for asymmetry. Comparing one side to the other is fundamental. You're looking for muscle wasting, which can be a critical clue pointing towards long-standing nerve issues or chronic disuse from pain. You're looking for swelling, any scars from previous injuries or surgeries, and observing the patient's overall posture or how they might be guarding the painful area. This initial visual assessment can be incredibly informative before you even lay a hand on the patient.
Like visually inspecting a machine before you start tinkering.
Exactly. You look for the obvious signs of wear, damage, or misalignment first.
And feel. What are we trying to find when we use palpation, when we touch the patient?
Feel involves palpation, using your hands to precisely locate tenderness over specific anatomical structures. This requires detailed anatomical knowledge and, frankly, a practiced touch. It takes time to develop that skill.
Specific spots matter.
Very much so. The sources give specific examples: feeling for tenderness directly over the coracoid process, that bony prominence near the front of the shoulder, which can indicate problems with the pectoralis minor tendon attaching there, or palpating the greater tuberosity, part of the upper arm bone where key rotator cuff tendons attach, or the bicipital groove where the biceps tendon runs. Tenderness in these specific spots points towards pathology, problems in those exact locations. You're also feeling for the quality of the tissues, any warmth suggesting inflammation, the joint congruence, how well the joint surfaces seem to align, muscle tone, and confirming any asymmetry you might have observed visually. Palpation adds a layer of tactile information that imaging simply cannot replicate. It's about getting a feel for the texture and structure, not just seeing a picture of it.
So precise anatomical knowledge guiding your touch is absolutely key. And then move. What does assessing movement tell us?
Move is all about assessing range of motion and strength. Critically, you assess both active movement, what the patient can do using their own muscles, and passive movement, what range you can move the joint through for them, gently.
And comparing those two is important.
It's diagnostically very powerful. If active motion is limited, but passive motion is full, it strongly suggests a problem with the muscles or tendons initiating the movement, perhaps weakness or even a tear. Conversely, if both active and passive motions are restricted, it points more towards joint stiffness itself, perhaps capsular restriction like you see in a frozen shoulder, or significant arthritis. The sources discuss assessing muscle strength properly, often using scales like the Medical Research Council (MRC) scale, and they explain the importance of knowing how to position the patient correctly to eliminate gravity's effect when testing true muscle power.
So technique matters there too.
Absolutely. They also highlight observing classic pain patterns related to movement. For example, Pain felt specifically in the mid-range of arm elevation, the so-called painful arc, often indicates subacromial impingement or rotator cuff issues, whereas pain only at the very top of elevation, the high arc, might point more towards problems in the ACJ, that joint on top of the shoulder. Observing these functional patterns during movement is a crucial part of the cluster. It's like stress testing a system component to see where exactly the failure occurs under load.
That detailed movement assessment sounds absolutely critical, giving insight into function as well as just structure. But the examination, according to the sources, shouldn't be confined just to the obvious area of complaint, should it? They mention looking elsewhere.
Precisely, and this is a vital point the sources really stress, and one that's sometimes overlooked in less thorough examinations. It is absolutely crucial to examine the joint above and the joint below the primary area of complaint,
Why is that so important?
because pain can often be referred from adjacent areas. The classic example they use, particularly relevant in children, is a slipped upper femoral epiphysis, SUAV. That's where the top of the thigh bone slips relative to the rest of the bone at the growth plate, right at the hip joint. Now, this condition frequently presents with pain felt only in the knee, with absolutely no hip pain reported by the child at all.
Really? Just knee pain from a hip problem?
Yes. So if you only examine the knee in that scenario, you will completely miss the underlying hip problem, which needs urgent attention. This principle applies everywhere. Neck problems can cause arm symptoms that mimic shoulder or elbow issues. Shoulder problems can cause elbow pain. Hip problems, as we said, can cause knee pain. Lower back problems can cause leg pain. Always checking the segments above and below is an essential safety net in your diagnostic process. It prevents you from missing the true source of the problem, which might be located elsewhere.
Like checking upstream and downstream processes when troubleshooting.
Exactly the same principle. The fault might not be where the symptom appears.
And given how often nerve issues intertwine with musculoskeletal pain, a neurovascular assessment seems particularly important here too.
It's absolutely essential. It must be a routine part of any comprehensive musculoskeletal exam. The sources really emphasize conducting a thorough neurovascular check. This includes assessing peripheral pulses to ensure adequate blood flow, which is usually straightforward, but critically, it involves a detailed neurological examination.
What does that involve?
They specifically mention checking key reflexes, providing examples like Hoffman's sign in the fingers or Babinski's test in the foot, which can indicate upper motor neuron issues originating higher ups, potentially in the cervical spine or even the brain. The inverted radial reflex is mentioned as a specific sign that can point quite strongly towards spinal cord compression at a particular level, C5, C6, in the neck. Then there's mapping out sensory changes using dermatome-specific skin areas supplied by single nerve roots and testing specific muscle groups supplied by particular nerve roots, known as myotomes. This is crucial for localizing nerve problems.
Well, you can pinpoint where the nerve issue is.
Exactly. It helps differentiate where along a nerve pathway the compression or injury might be occurring. This is especially vital in complex conditions like brachial plexus palsies, those injuries affecting the network of nerves running from the neck into the arm. This level of detailed neurological testing is indispensable for including or excluding a nerve as the primary source of the problem or identifying it as a contributing factor. It's like meticulously tracing the wiring diagram in a complex system to see exactly where the electrical signal is failing or being interrupted.
Right, a truly comprehensive approach covering nerves and blood vessels too. So we've built the picture with the history and we've observed and felt the system with the physical exam. That brings us to the third pillar, diagnostic testing or investigations. How do the sources advise framing the role of these tests within the overall diagnostic process? Should they come first?
No, their role is presented very clearly, and I think correctly, as primarily confirmatory, not as standalone diagnostic tools in their own right. This is a critical distinction the sources repeatedly underline, really pushing back against a common tendency we see towards over-reliance on technology.
So tests support the diagnosis, they don't make it?
Precisely. Tests like X-rays, ultrasound scans, MRI scans, CT scans, they should be used to support or perhaps refine the clinical diagnosis you've already started to formulate based on the history and the physical examination. They shouldn't be the sole basis for making a diagnosis in isolation. This is a fundamental principle they advocate for, partly to combat the overutilization of imaging we often see today, which can lead to increased costs and sometimes incidental findings that confuse the picture. The clinical assessment should lead, the investigation should follow to confirm, refute, or clarify.
Okay, so they confirm they don't diagnose on their own. Could you give us a quick rundown of some of the types of investigations mentioned in the sources and what they are particularly useful for in this musculoskeletal context?
Certainly. Plain X-rays are often a very good initial step, especially after trauma, to look for obvious fractures or dislocations. They're also key for assessing features of established arthritis, like loss of joint space, bony spurs known as osteophytes, or cysts within the bone. Ultrasound is highlighted as being excellent for dynamic assessment, meaning you can look at how structures move in real time, like tendons gliding. It's very good for visualizing soft tissues close to the surface, like tendons, identifying fluid collections around structures like the biceps tendon, assessing certain types of rotator cuff tears, and importantly, it's widely used now for guiding injections accurately or performing aspirations, for instance, in cases of calcific tendinitis where you might want to break up calcium deposits.
Right, and MRI,
Right.
often seen as the gold standard.
MRI is generally considered the gold standard for detailed visualization of soft tissues. It's excellent for assessing the extent and characteristics of rotator cuff tears, identifying tears of the labrum, that cartilage rim in the shoulder or hip, like SLAP lesions in the shoulder. It can detect cysts, inflammation within the bone, and crucially, assess fatty atrophy or infiltration within muscles, which can be a sign of chronic nerve issues or very long-standing tendon tears. CT scans, on the other hand, provide superior detail of bony anatomy. They're invaluable for assessing complex fractures, particularly those involving joint surfaces. They're also used for measuring bone loss, for instance, assessing the glenoid bone stock in the shoulder socket before instability surgery, evaluating the degree of bone wear in advanced arthritis, or sometimes visualizing rotator cuff muscle wasting in cross-section. Finally, mention MR arthrography. This involves injecting contrast dye directly into the joint before an MRI scan. This technique can be particularly useful for visualizing structures like the labrum or the joint capsule more clearly, especially for detecting subtle tears like some SLAP lesions that might be missed on a standard MRI.
That covers the main imaging techniques quite well. But the sources also dedicate significant attention to investigations specifically for nerve-related issues, which sounds like a distinct category requiring different tools.
They do, yes. And they are quite emphatic that for diagnosing problems with nerve function, nerve conduction studies, NCS, and electromyography, EMG, are really the gold standard investigations.
How do they differ from imaging?
Unlike imaging, which primarily shows the structure of the nerve or the structures around it, NCS measures the nerve's actual function, how quickly and how effectively it's conducting electrical signals along its pathway. This helps pinpoint the exact location of a compression or injury along the nerve. EMG, often done at the same time, assesses the electrical activity within the muscle supplied by that nerve. Abnormal patterns on EMG can show whether the muscle is receiving insufficient nerve signals, that's called denervation, or perhaps if it's showing signs of the nerve starting to recover after an injury.
So they test function directly.
Exactly. These tests are crucial for conditions causing weakness, numbness, or tingling that aren't clearly due to a local muscle or joint problem. Examples include weakness of the trapezius muscle due to spinal accessory nerve palsy, or serratus anterior weakness causing scapular winging from long thoracic nerve palsy, or assessing the severity and potential for recovery in brachial plexus injuries. They provide objective functional data about the nerve itself, which imaging alone cannot provide.
That's a really comprehensive overview of the three pillars and the tools within them. But as we established right at the start, the fundamental argument of these sources, the core message for practical diagnosis, is that these cannot and indeed must not be used in isolation. This is where the diagnostic cluster concept truly comes alive, bridging that gap between theoretical knowledge and everyday practice.
Exactly right. The central tenet, the real practical wisdom these sources aim to impart, is that while academic resources might meticulously detail isolated components, a specific history question, a single physical test, or a particular imaging finding, they often fall short of illustrating, as they phrase it, the cluster approach one needs to use in everyday practice. They argue that this integration, this synthesis, is the real skill of diagnosis.
So moving beyond simply listing the components, why does combining findings into a cluster significantly enhance diagnostic accuracy compared to relying on individual elements like one special test?
Because, as one source rather directly puts it, excessive reliance on a single special test is not recommended. And the reason for that is that individual tests, even those that are widely taught and commonly used, often have limited and crucially variable sensitivity and specificity depending on the specific context and the patient population being tested.
So a positive test isn't always truly positive for that specific condition.
Precisely. A single test might be positive, but if its specificity is low, that positive result could mean several different things, not just the one condition you suspect. Relying solely on one such test is inherently risky and, frankly, frequently misleading. However, when you combine multiple pieces of information, say, a specific pattern you've identified in the history, several compatible findings on your physical examination, and then perhaps confirmatory, or sometimes exclusionary, results from appropriate investigations, the collective weight of that evidence becomes far more robust and reliable. A potentially weak or nonspecific finding from one part of the cluster gains significant diagnostic power when it clearly aligns with findings from the other parts. It's like building a compelling case in court. A single piece of circumstantial evidence might not convince a jury on its own, but multiple pieces of evidence from different sources, all pointing consistently in the same direction, become overwhelmingly persuasive.
They use the example of shoulder impingement tests to illustrate this point quite effectively, don't they?
They do, and it's a very powerful illustration of the principle. They cite a meta-analysis, a study that combines results from multiple previous studies, which found that commonly performed physical tests for shoulder impingement, that painful condition where tendons or the bursa might get pinched when you lift your arm, specifically tests like Neer's test and the Hawkins-Kennedy test.
Yes, I think many people have had those done.
Quite likely. The meta-analysis found that these tests, despite often being quite sensitive, meaning they tend to be positive if impingement is present, actually had poor diagnostic utility when used in isolation.
Meaning they don't reliably confirm the diagnosis.
Exactly. A positive result doesn't reliably confirm impingement on its own because these tests can also be positive in other shoulder conditions. They aren't specific enough. They do mention another test, the internal rotation resistance strength test, which some data suggests might improve the post-test probability of impingement, meaning it might add more value. But they carefully note that the quality of the supporting data for that test is variable. So this example directly supports their central thesis. Single special tests, even well-known ones, are rarely definitive. Accurate diagnosis requires the synergy of multiple findings forming a compelling, coherent cluster.
That really drives home the point, doesn't it? It's not about finding the one magic indicator. It's about the careful synthesis and the intelligent weighing of multiple pieces of information.
Precisely. It's about pattern recognition across different data types. And this principle, I believe, is universally applicable well beyond medicine.
Absolutely. So let's explicitly connect this back to our listener. They might be wrestling with complex problems in, say, finance, technology, management, HR, or any other professional field. How does this concept of thinking in clusters of information, combining diverse data points rather than fixating on a single metric or observation, translate to improving their decision-making outside of a clinical setting?
It's a very direct parallel, I think. In any complex professional domain, you are constantly faced with different types of information, aren't you? You have qualitative input, things like a client's feedback, an employee's perspective, maybe a historical account of how a project unfolded.
The history part.
Exactly. Then you have observed phenomena, the performance metrics you track, process bottlenecks you actually witness, team dynamics you observe in meetings. That's your examination. And then you have objective data, financial reports, system logs, sales figures, market research data. That's your testing or investigations. Now, over-relying on just one type of data, say, making a major strategic decision based solely on a single financial report, or diagnosing a team's performance issue based only on one disgruntled person's complaint, or perhaps approving a significant system change based on a single successful test result viewed in isolation that is the non-medical equivalent of doing just one special orthopedic test and basing everything on that. It's inherently flawed.
So the cluster approach in business or tech would mean?
It means deliberately gathering inputs from various stakeholders, the history. It means analyzing multiple relevant metrics, not just one favorite KPI, the testing. It means observing the actual processes or behaviors firsthand, the examination. It means reviewing historical trends and context. And then, crucially, it means synthesizing all of that information together. You're looking for patterns that emerge across these different data streams. Does the client feedback actually align with the sales figures? Does the process bottleneck you observed correlate with the system log errors you found? Does the employee's perspective make sense when you look at the team's overall performance metrics and project timelines? Only by combining these different types of information into a comprehensive cluster can you truly understand the complexity of the problem, identify its likely root cause, and then make a robust, reliable decision on how best to address it.
So better diagnosis leads to better solutions.
Fundamentally. Effective solutions, effective strategies, positive outcomes in any field are ultimately dependent on an accurate and comprehensive diagnosis of the situation you're facing. And that diagnosis, that deep understanding, comes from the cluster, not from relying on a single, potentially misleading data point. The sources couldn't be clearer on this. Getting the problem definition right through this integrated approach is the indispensable first step to achieving your desired outcome.
That connection is incredibly powerful. It really elevates the clinical example into a universal principle for navigating complexity in almost any professional setting. Okay, let's transition slightly now and apply this framework to some specific examples of complex problems, both within the musculoskeletal domain to see it in action,
Right.
and maybe hinting at how these challenges manifest elsewhere.
Right. The sources then proceed to illustrate how these principles are applied to specific orthopedic conditions, detailing the specific clusters of findings that typically guide diagnosis in those cases. Let's take shoulder arthritis, for instance. The diagnostic cluster here usually involves, first, a history of progressive pain and a gradual loss of shoulder motion. Often, this loss of motion affects all directions of movement fairly equally over time, a sort of global restriction. Then, on examination, you typically find this generally restricted range of motion confirming the history, both when the patient tries to move, active, and when you move their arm for them, passive. Imaging is crucial here too. Plain X-rays will typically show the hallmark features: narrowing of the joint space where the cartilage is worn away, bony spurs or osteophytes forming around the joint edges, and sometimes cysts forming in the bone underneath.
So x-rays are key for arthritis.
They are often sufficient for diagnosis, yes. But for significant arthritis, particularly if surgery is being considered, cross-sectional imaging, like a CT scan, often becomes vital. This helps the surgeon assess things like the amount and quality of bone remaining in the socket, the glenoid bone stock, and the pattern of wear, which informs surgical planning. And, crucially, you must also assess the function and structural integrity of the rotator cuff muscles and tendons, often requiring an MRI because significant pain from the arthritis can make clinical strength testing unreliable. So you see, it's the history of progressive pain and stiffness, plus the specific exam findings of global restriction, plus the characteristic imaging features on X-ray and possibly CT-MRI that cluster strongly points towards arthritis as the diagnosis.
And what about something like shoulder instability? That sounds like it could present in many different ways, making the cluster even more important.
Instability is a prime example, where the history takes center stage within the cluster, really guiding the rest of the assessment. You absolutely need to know: was the instability caused by a significant trauma, like a fall or a sports injury, leading to a dislocation? Or did it develop more gradually without a specific injury, what we call atraumatic instability?
Traumatic versus atraumatic.
Yeah.
Big difference.
Huge difference in terms of underlying causes and treatment approaches.
Yeah.
You also need to clarify: are they experiencing frank, complete dislocations where the shoulder comes right out and needs putting back in? Or is it more subtle sensations of the shoulder slipping out partially and then going back in what we call subluxations? Were there any nerve symptoms like numbness or tingling or associated fractures at the time of the injury? This detailed history provides the initial classification and raises the level of suspicion. The examination then uses specific provocative tests designed to reproduce the patient's feeling of instability. For anterior instability, the most common type, where it slips forward, tests like the apprehension and relocation tests are key. For posterior instability, slipping backwards, tests like the load and shift or the jerk test assess how much the joint surfaces can be moved relative to each other.
And you mentioned hypermobility.
Yes. Part of this cluster, particularly for atraumatic instability, often involves assessing the patient's generalized joint flexibility or hypermobility, perhaps using a scoring system like the Baton score. This can point towards underlying conditions that affect connective tissue laxity throughout the body, making joints inherently less stable. Imaging, usually starting with plain X-rays, is needed to check for any bony damage that might have occurred during dislocations. Common findings include Hill-Sachs lesions, which are dense in the back of the upper arm bone, or Bankart lesions, damage to the front rim of the socket. Sometimes special angled X-ray views, like the West Point or Stryker notch views, are needed to see these clearly, or even a CT scan if there are complex bony defects that might require surgical repair. So again, the cluster is the patient's specific story of how and when it happens, history, combined with specific physical tests that reproduce the instability, exam, and imaging confirming any resulting structural damage investigations.
You also mentioned nerve palsies earlier as being particularly challenging diagnoses that rely heavily on this cluster approach because the symptoms can be vague.
They are indeed challenging, precisely because the main symptoms, often pain, weakness, sometimes numbness, can mimic so many other common musculoskeletal issues like tendinitis or arthritis. Diagnosis relies very heavily on integrating the history, some very specific clinical signs that might be subtle, and those specialized investigations we talked about, namely NCS and EMG. For example, suprascapular neuropathy, where a nerve near the shoulder blade gets compressed, perhaps by a cyst. This can cause a deep, aching pain, often felt on the back or side of the shoulder, along with specific weakness in two of the key rotator cuff muscles, supraspinatus and infraspinatus. Clinically, you test the strength of those specific muscles very carefully. Imaging like MRI is often better than ultrasound in this case for actually seeing a compressing cyst near the nerve. But crucially, NCFMG studies are essential to confirm that the nerve itself is damaged or compressed, help locate the exact site of compression, and assess the severity of the nerve injury.
So, clinical suspicion plus imaging plus the nerve tests.
Exactly, that's the cluster. Another complex example is brachial plexus palsy, involving injury to that whole network of nerves in the neck and shoulder region that control the arm and hand. This often follows high-energy trauma, like a motorbike accident. A critical diagnostic step here is differentiating between preganglionic injuries, where the nerve root is actually pulled away from the spinal cord itself. These are often very severe, and postganglionic injuries, where the damage is further along the nerve pathway, potentially less severe or with a better prognosis for recovery. This differentiation relies on identifying subtle but specific clinical signs during the neurological exam. Things like Horner syndrome, a specific pattern of facial droop, constricted pupil, and reduced sweating on one side, which indicates very high nerve root involvement. Or scapular winging, where the shoulder blade sticks out abnormally, often due to long thoracic nerve damage. Or looking for atrophy, wasting, of specific muscles like the rhomboids between the shoulder blades or the small intrinsic muscles within the hand. Reflex changes are also key. These clinical findings, which require a really meticulous neurological exam, are then combined with NCSMG results. These tests are truly the gold standard here, confirming the presence, the location, pre versus postganglionic, and the type of nerve damage, and also providing crucial prognostic information about the potential for spontaneous recovery. Without this integrated cluster, the history of high-energy trauma, the specific clinical signs like winging or hand intrinsic weakness, and the objective nerve function tests from NCFJEP diagnosing and planning treatment for such complex nerve injuries would be virtually impossible.
So, for these complex nerve issues, that specific investigative pillar, the NCSMG, becomes almost the centerpiece that ties the clinical findings together within the cluster, confirming the functional deficit. The sources also make it quite clear that this cluster concept applies universally across the entire musculoskeletal system, not just the shoulder, which they use as a major example area. Can you give us a few quick examples from other areas, perhaps highlighting a specific historical clue, an examination finding, or a test that forms a key part of a diagnostic cluster elsewhere in the body?
Certainly. If we move down to the elbow, common diagnoses like medial or lateral epicondylitis, better known as golfer's elbow, medial, or tennis elbow, lateral, heavily rely on the history, pinpointing the pain location, inside or outside the elbow, combined with specific physical provocation tests. Resisting wrist flexion often reproduces medial elbow pain, while resisting wrist extension typically provokes lateral elbow pain. That combination is key. For the wrist and hand, the sources note that diagnosis often leans very heavily on the history, partly because physical signs can sometimes be quite subtle, a paucity of signs, as they put it. So you need to combine that detailed history with specific examination findings. For example, Dupuytren's contracture, that condition causing fingers to curl into the palm. The cluster includes the history of noticing thickening or palpable cords developing under the skin in the palm, combined with the classic physical exam finding of being unable to lay the hand completely flat on a table. That's Houston's tabletop test. For trigger finger, where a finger clicks or gets stuck when bending, is the classical history provided by the patient, combined with the examiner finding a palpable, sometimes tender nodule when they feel along the tendon sheath in the palm. Hand arthritis diagnosis involves identifying which specific joints are affected, as the pattern is often characteristic. Osteoarthritis classically hits the end joints of the fingers, the DIP joints, often with bony enlargements called Heberden's nodes, whereas rheumatoid arthritis typically affects the knuckle joints, MCPs, and the middle joints of the fingers, PIPs, classically sparing the DIP joints. Recognizing this pattern on examination is a key cluster element for differentiating arthritis types.
So the pattern of joint involvement is crucial.
Very much so. Then, for nerve entrapments, like carpal tunnel syndrome, which is compression of the median nerve in the wrist, the cluster involves the history of classic symptoms tingling or numbness, typically in the thumb, index, middle, and the thumb side half of the ring finger, often worse at night. This is combined with positive provocation tests like Phalen's test, holding the wrists flexed, or Tinel's sign, tapping over the nerve at the wrist. And importantly, testing sensation in the specific distribution of the median nerve is key, including the area over the base of the thumb, the thenar eminence. Interestingly, preserved sensation right there helps distinguish carpal tunnel syndrome, where that area is usually spared, from a median nerve problem originating higher up in the arm or neck. For ulnar nerve issues, which can occur either at the elbow, funny bone area, or the wrist, specific signs like Wartenberg sign, where the little finger drifts away from the others involuntarily, or visible clawing of the fingers, particularly the ring and little fingers, are key examination findings that form part of the diagnostic cluster.
Yeah. And the spine. Another area notorious for complexity and overlapping symptoms. How does the cluster approach apply there?
The spine absolutely requires a rigorous cluster approach. Take low back pain, incredibly common. A key challenge is differentiating between straightforward degenerative issues, like arthritis or disc wear and tear, neurogenic causes, like nerve root compression from a disc bulge or spinal stenosis, causing sciatica down the leg, or even vascular claudication, leg pain caused by poor blood flow from peripheral artery disease, which can mimic nerve pain but has a different pattern, typically worse with walking distance, better with rest, and usually unaffected by spine position. Each of these has a distinct historical pattern and typically different findings on physical examination. E.g., neurological deficits like weakness or reflex changes point towards a neurogenic cause, whereas checking pulses and skin changes in the feet is important if vascular claudication is suspected. A critical emergency diagnosis related to the spine is cauda equina syndrome, where the bundle of nerves at the very base of the spinal cord gets compressed, often by a large disc herniation. This is diagnosed by recognizing a specific cluster of red flag symptoms and signs appearing together. These include severe leg pain, often bilateral, significant motor weakness or sensory deficit in the legs, and crucially, changes in bowel or bladder function, like incontinence or retention, or numbness in the saddle area around the groin and buttocks. Recognizing this cluster is paramount for urgent surgical referral. For scoliosis, which is curvature of the spine, diagnosis involves the history. When was it noticed? Is it progressing? Is there pain? Combined with a key physical exam maneuver like Adam's forward bend test, where the patient bends over, making the rotational aspect of the curvature much more visible as a rib hump or loin prominence.
What about the lower limbs, hip, knee, foot, ankle? Similar principles apply.
Again, absolutely. The principles hold true. Referred pain is a major consideration, particularly around the hip and knee. As we discussed earlier, the classic example of a slipped upper femoral epiphysis, SUFE, in an adolescent presenting only with knee pain underscores the absolute necessity of examining the hip joint in any child or adolescent presenting with knee pain, regardless of what their history initially suggests. You just have to check. For the knee itself, the timing of swelling after an injury is a vital historical clue within the diagnostic cluster. Immediate tense swelling developing within hours usually indicates hemarthrosis, significant bleeding into the joint. In the context of an athletic twisting injury, this finding carries a very high probability, perhaps 70–80% according to some sources, of signifying an ACL, anterior cruciate ligament, rupture. Gradual swelling that appears over 24 hours or more suggests a different type of joint effusion, perhaps related to a meniscal tear or cartilage damage, rather than major ligament disruption. Moving down to the foot and ankle, careful observation for deformities is key, as these can indicate underlying issues. Foot shapes like pes cavus and abnormally high arch, or visible clawing of the toes could immediately raise suspicion for potential underlying neurological conditions situated higher up, possibly in the spinal cord like spine dysraphism, or affecting the peripheral nerves like Charcot-Marie-Tooth disease or Friedreich's ataxia. These foot signs are part of a broader cluster that absolutely demands a thorough neurological and spinal examination.
So the foot can be a window to problems elsewhere.
It absolutely can be. Another specific example from the sources is posterior tibial tendon disruption, a very common cause of adult-acquired flat foot deformity. The diagnostic cluster here typically involves a history of progressive pain and swelling along the inner side of the ankle and arch. This is coupled with key physical findings. Visually, when the patient stands and you look from behind, you might see the too many toes sign, meaning more of the lateral little toe side of the forefoot, is visible on the affected side compared to the unaffected side. This indicates the arch has collapsed and the foot has consequently rotated outwards. Then, functionally, the patient will often be unable to perform a single-leg tiptoe test successfully on the affected side, demonstrating weakness in the posterior tibial muscle, which is the key dynamic supporter of the foot's arch. That specific combination, the history, the visual observation, too many toes, and the functional test, failed tiptoe, forms a strong diagnostic cluster for this particular problem.
The too many toes sign. That's such a specific, memorable detail from the source material, isn't it? It really highlights how even a seemingly subtle visual cue, when combined with the history and a functional test, can become a critical part of the diagnostic puzzle.
Exactly. It's often these specific, sometimes seemingly minor signs gleaned from a thorough history or a meticulous physical examination that, when placed within the context of the full cluster of information, either strongly confirm or help refute a potential diagnosis. They add significant weight to the overall picture.
Speaking of challenges, though, the sources also highlight several potential pitfalls that can derail the diagnostic process, even when someone is consciously trying to use a cluster approach. What are some of the key ones that professionals, perhaps in any field, should be particularly aware of?
Well, a major pitfall, as we've touched upon quite a bit, is the persistent tendency towards overutilization and the resultant risk of overdiagnosis, often driven by an excessive reliance on imaging findings without adequate clinical correlation. This can easily lead to treating scan findings like age-related disc bulges or partial tendon tears that aren't actually the cause of the patient's current problem.
Chasing ghosts in the machine?
In a way, yes. Another significant challenge, particularly relevant in clinical examination, but certainly applicable more broadly when assessing any system under stress, is the issue of pain inhibition. Severe pain can simply make a patient unable or unwilling to move fully or exert maximal strength. This can potentially mask underlying issues like true muscle weakness or joint instability because the pain stops them before you can properly assess it. You have to find ways to work around that, or at least account for that confounding factor in your interpretation. Subtle presentations are also inherently difficult. Some conditions genuinely have minimal objective signs, like many chronic wrist problems where the history becomes paramount. Or there are issues that are easily overlooked unless specifically considered, like certain types of shoulder impingement, coracoid impingement, or partial pectoralis major tendon ruptures. These require a very high index of suspicion and meticulous attention to detail within the cluster to pick them up. And, as mentioned briefly, pediatrics has another layer of complexity. Children's bodies are different. The conditions they get can be different. You often rely heavily on the parent's interpretation of the history, and you need to adapt your examination techniques for a potentially anxious or uncooperative child. It requires extra patience, flexibility, and specific knowledge.
It seems like navigating these pitfalls, being aware of bias, confounding factors, subtle signs, is just as important as knowing the steps of the process itself. Finally, bringing all these pieces together, meticulously gathering the information, identifying the coherent cluster, arriving at a comprehensive diagnosis, how do the sources explicitly connect this diagnostic accuracy to actual patient outcomes? Is there a direct link?
They draw a very direct and very strong link, presenting it almost as a foundational principle for effective healthcare. They state quite unequivocally that effective treatment is dependent on a comprehensive diagnosis.
It seems obvious, but maybe it's easily forgotten.
Perhaps. The logic they present is straightforward. If your understanding of the problem your diagnosis is imprecise, incomplete, or simply wrong, then the solution or intervention you apply is highly likely to be equally flawed, misdirected, or irrelevant. This leads directly, they argue, to unreliable treatments and consequently to poor patient outcomes. A truly comprehensive diagnosis doesn't just involve putting a label or a name on a disease. It integrates the specific anatomical issue with the patient's overall health context, their functional limitations, their goals and expectations, and even relevant psychosocial factors. It's this rich, multi-layered understanding that truly informs the content and the timing of appropriate interventions. It guides whether surgery, specific types of therapy, medication, watchful waiting, or something else entirely is the most appropriate path forward and when it should be implemented. So getting the diagnosis right isn't just an academic exercise in pattern recognition. It is, according to these sources, the absolutely indispensable first step towards achieving successful treatment results and positive outcomes. Whether those outcomes are measured in terms of a patient's pain relief, their functional recovery and return to activity, or even system-level efficiencies and appropriate use of resources.
That truly underscores the critical importance of mastering this diagnostic process, not just performing it perfunctorily.
It does. And the sources implicitly argue that professionals, clinicians, in this specific case, but arguably any professional dealing with complex problems, have a responsibility to invest the time and the intellectual effort required to continually improve their capabilities in history taking or context gathering, physical examination or system observation, and the judicious interpretation and integration of investigations or objective data. It's presented as an investment that pays significant dividends in terms of diagnostic accuracy and, ultimately, in achieving better outcomes for the patient, the client, the project, or the organization. And as we've discussed throughout, this core principle extends far beyond medicine into almost any professional domain where complex problems need to be understood and solved effectively.
Fascinating insights, really drawing that connection strongly. Let's shift gears slightly now for a quick lightning round, pulling out some rapid insights and practical tips from the sources that our listeners can perhaps immediately grasp and think about. Prof, what's one key general sign or observation you should always look for when systematically assessing any complex situation or system, drawing from the principles in these texts?
I'd say asymmetry. In almost any system, whether biological or organizational, significant asymmetry often points towards something being fundamentally wrong, unbalanced, or compromised on one side or in one part compared to the other. Always compare and contrast. Look for the differences.
Okay, asymmetry. Beyond relying on standard, easily accessible reports or data, what's an investigation technique or type of analysis mentioned that's particularly valuable for digging deeper into specific types of issues, especially those related to function?
The nerve conduction studies and electromyography, NCSEMG, stand out. They represent a category of diagnostics that fundamentally assess function, not just structure. That's crucial for certain types of problems, where the structure might look normal on a scan, but the system isn't working correctly. Perhaps think about how you can use functional testing alongside structural analysis in your own field.
If you could give just one piece of advice about avoiding diagnostic pitfalls, based on the wisdom distilled in these sources, what's the single most important rule to follow?
Never, ever over-rely on a single piece of data or a single test result, no matter how compelling or technologically advanced it seems in isolation. Always integrate it with the full context and all the other findings, and perhaps value the history, the background story, the context above all else, at least initially. Let that guide your inquiry.
What's a book or perhaps a type of resource, mentioned either implicitly or explicitly, that professionals who are interested in genuinely mastering diagnosis or complex problem solving could explore further?
I would suggest looking for resources that explicitly aim to bridge theoretical knowledge with practical application in diagnosis or problem analysis. Focus on resources that emphasize the integration of different data streams and teach you how to reason clinically, diagnostically, or systematically, not just list facts, tests, or isolated metrics. The concept behind a resource titled something like the shoulder clusters, as mentioned in the source material, exemplifies this practical integration focus. Seek out that kind of applied wisdom.
And finally, thinking about applying this immediately, what's one quick win takeaway that any professional listening could potentially apply to their own problem-solving process this week?
Okay, a quick win. Before you jump to proposing a solution for a complex problem you're facing, pause. Deliberately take a moment to list out, perhaps just briefly, the history, the context, the background, what led up to this issue, the examination findings, what you currently observe about the problem state, how the system is behaving, and any test results, the objective data or metrics you have. Then simply ask yourself, does the story from these different sources align? Do they point in the same direction? Don't just jump to fixing based on only one of those inputs. Check for consistency first.
That rapid-fire round really crystallized some powerful, actionable points applicable far beyond the original medical context. Let's bring it all together now with some key takeaways for you, our listener, to perhaps carry forward and reflect on. First, effective diagnosis and sophisticated problem solving in any complex domain fundamentally rely not on finding that single magic bullet or KPI, but on the systematic combination and synthesis of information from multiple sources, your version of the history, the examination, and the testing. You need to consciously embrace this cluster approach. Second, never underestimate the power of gathering thorough initial context, much like a comprehensive clinical history that includes background, influencing factors, lifestyle-related issues. This provides crucial, often overlooked clues and insights that isolated data points or surface-level observations will simply miss. Dig deep into the why and how. Third, invest time and effort in skilled observation and systematic assessment. A physical examination of your problem, really looking at it, maybe feeling its behavior, testing its movements and reactions under different conditions, reveals vital signs and patterns that go beyond the surface level symptoms or complaints. Learn to look broadly, including the connections to adjacent parts of the system, the joint above and below. Fourth, remember that objective data, tests, scans, reports, analyses, they are incredibly powerful tools, but they are primarily confirmatory and require careful clinical or contextual correlation to be truly meaningful. You must actively guard against the common pitfall of over-relying on a single report or test result to make your entire diagnosis or base a critical decision. Finally, and perhaps most importantly, recognize that a truly accurate and comprehensive understanding of the problem built diligently through this multifaceted cluster approach is the indispensable, non-negotiable foundation for developing effective strategies, targeted interventions, and ultimately achieving the successful outcomes you desire in any professional pursuit. Getting the diagnosis right really is the first, most critical step to success. Thank you so much for joining us for this deep dive into the diagnostic cluster approach. It seems clear that mastering the art and science of diagnosis is perhaps less about having the single most advanced tool and much more about the skilled integration and interpretation of all the available information. If you found this deep dive valuable, please do consider rating and sharing the show. It genuinely helps others discover these crucial insights and think about how they might apply them in their own complex fields.
It's been a truly insightful exploration, highlighting principles that really do govern effective problem-solving in countless domains, well beyond the clinic.
Indeed. Until next time, keep asking those probing questions, keep meticulously examining the evidence, keep looking for the pattern within the cluster, and keep diving deep. I'm your host, and this has been The Deep Dive.